Hello and welcome to the Imaging Wire Show. My name is Brian Casey. I'm managing editor of the Imaging Wire. Got a great episode for you today. Our topic is the annual exam of the future, and our guest is Dr. Daniel Durand. He is Chief Medical Officer at Prenuvo. Dr. Durand, thanks for being with us today.
Thanks, Brian. It's a pleasure to be here as always.
Great. Dr. Durand, can you tell us about Prenuvo and about your role at the company?
Absolutely. As you referenced, Prenuvo is a company that's trying to bring the world the exam of the future. And this has started with whole body MRI. And more recently, it's extended to a variety of biomarkers in sort of a blood panel. And it will be shortly extending well beyond that. And we began as the first set of clinics across the world that is focused exclusively on whole body MRI. And we are evolving into the same thing, a set of great clinics spread across the entire world, but focusing on the annual exam of the future.
Awesome. So how long has this idea of preventive screening been around? Can you walk us through the evolution of it and kind of how we got up to the stage where Prenuvo's at?
Well, if you think about it through the lens of the exam of the future, the physical exam has been around well over 100 years. It's sort of like the linchpin of really the American care model and maybe the modern Western care model. If you look at value-based care models, things like ACOs, insurance companies, or even just what most providers will say, really good healthcare kind of begins and ends with that annual check-in with a doctor of some sort. But all of us know all too well, and we aren't surprised to learn, right, that sometimes you can get that annual check-in at its current iteration where a doctor might meet with you, ask you questions, order a limited set of labs, do only the recommended screenings, and do a thorough physical. But you wouldn't be surprised to learn because it happens all the time if somebody were to tragically die a week later of let's say an aneurysm, or if maybe a mother of five in her late 30s or something were to be diagnosed with stage 4 breast cancer a few months after her annual appointment. Like, it doesn't surprise us. And really what we're trying to do at Prenuvo is create a world where the annual exam is so good that you would be shocked if either of those things happened. And I'm not saying that we're there, from a medical claims perspective today, but that's the goal here is to be constantly incorporating the latest and greatest technologies to non-invasively take as much information as we can and get to that outcome. And people have been thinking about this, I would say, for decades. So if we say that the physical exam or the annual check-in is hundreds of years old, which I think we can say that, the idea about using technology to get that to be better has been around at least several decades. And within radiology, we know about things like mammograms, et cetera, these targeted exams. But we also know that about 20 years ago, there was this first wave of centers doing whole body imaging. And at that time, it was mostly CT. And in everybody's memory, this was exclusively private centers because the thing came and went. But if you go back and you read the literature, actually, a lot of AMCs were doing this, to my understanding, because it's in the literature at the executive health level. So this wasn't a minority viewpoint back then. And it didn't pan out back then for a variety of reasons. One reason is CT is probably not the right modality for it. Experimenting with whole body MRI in this regard really started in the late 2010s. And one of our founders of Prenuvo, Dr. Raja Tarawala, he began the AIM clinic in Canada at around that time, 2008, 2009. And so our experience in this as a medical practice really does extend back over 15 years at this point in terms of optimizing the protocols to get that whole body MRI annual exam. Others have joined in, right? Over time, we have competition from all sorts of places. And if you just Google today whole body MRI, you'll see it's not just Prenuvo, right? You'll see it's all sorts of places, lots of independent practices. I would love to know what percent of physicians at this point are part of an organization that does this in one way or the other, because I think we're getting well over 10% is my belief. So this is no longer the bleeding edge, honestly. This is becoming part of, I would say, early adopter practice. And the last thing I'll say is on the peds side, which is where I've spent part of my career because I'm dual boarded. I have a CAQ in peds. We saw whole body MRI get very, very tightly embraced in the high risk populations, the pediatric cancer predisposition populations, where it's now part of guidelines for conditions like Lee-Fraumeni. And as those patients have survived better, right, they've also extended beyond the pediatric lifespan into the adult health span. And so you're now seeing adults get this service covered by insurance in certain contexts. That's not part of our care model, although we do have some of those patients come into our care model and pay cash to get the service with us for various different reasons, sometimes around access. So this is really something that's been around for a while. It's definitely more widely adopted in high risk pools than normal risk pools. And I think, again, if you type into ChatGPT or almost any LLM, with the exception of Open Evidence, it gave me a slightly different answer. But all the other LLMs, when I ask it, how long will it be until whole body MRI is fully embraced and is part of the standard annual checkup? It'll almost always say somewhere between 5 and 10 years, if you ask any. So to the extent that we all think LLMs maybe are better than human doctors or human doctors plus, all these latest things that are coming out about how great these LLMs are. Well, I'll say the LLMs really think this will be part of standard care within the decade.
Wow, interesting. Well, let's talk a little bit about Prenuvo. So you're in this whole body MRI screening space. Can you talk about the formation of the company and a little bit about the company's background and what you're doing right now?
Yeah, the company began in the late 2000s in Canada, and for the first 10 years or so, it was. I mean, I was up there visiting around that time. It was a small group of people, one scanner type shop, and they were pioneering this whole body MRI screening situation. And at some point, let's say 2016 or 17, my boss, our CEO, the co-founder, Andrew Lacey, he visited that practice as an interested entrepreneur and patient and was just blown away with his experience. And he felt that he got more data for him, the way he thinks, right? He got more data about his health in that hour or so in the scanner and then the hour with the doctor that than he felt he had gotten his entire life elsewhere in the health system. For him, that data was extremely meaningful. And he felt here is something that others will resonate with. And so they began this process of building a company, finding kind of product market fit. What will this look like if we really try to scale this? And they brought this service first, right in the middle of COVID, to Silicon Valley, where it was a huge hit. And then from there to LA and a few other places. I've been with the company at this point around 20 months. And we've gone, I think when I joined, we were around 10 centers. Now we're kind of in the mid 20s. We used to be just in Canada, then we were in the United States, right? Now we're in Australia as well, and within months we'll be in the United Kingdom. So this is something that's going really throughout the world. And the key to Prenuvo is we're a tightly integrated service, and whatever we do, we really try to be best of breed in that. And obviously, you can't be best of breed in everything, but we started by being best of breed in whole body MRI because we think that is where you get the most data. It's not the test that solves everything, but it's a test that solves more than any other test, in our opinion, with regard to early detection and sort of biomarker gathering and optimization. And if you can do that plus blood, you have a really good coverage for many things. We will be adding some additional modalities. We will certainly be going deeper in MRI in areas that we aren't currently doing today. But the vertical integration is the idea that we have all these machines made to spec, made a very certain way. And we have all the technologists employed by us. We buy the same types of coils. We run the same exact protocol. We have daily phantom tests that are the same everywhere on Earth. And one of the reasons we use 1.5T, for example, versus 3T, which I'm going to talk radiologies, which I can't hear because this is a radiologist type venue. And normally I
Go
can't.
for it.
Great. Everyone says that. Why not 3T? You can often get better signal to noise. Yeah, but you also get higher artifacts. And so when you're doing the game that we're doing, which is large numbers, trying to get great results for patients across the world, you kind of have to step out of that that sort of artisanal approach that you might have in an academic center, right? Where you have like the best tech in the world and the best radiologists in the world, although you might have a different one every other day, right? And they're kind of doing their thing and tinkering. But we want to bring the same thing consistently to everyone, to the masses, to millions. And 1.5, we believe is at this point in time is better for that because we find that increased field homogeneity, that sort of like lower susceptibility artifact, particularly on the diffusion weighted scans, which really are the key, not just to finding cancer. Honestly, it's the key to finding abnormalities in general on non-contrast whole body MRI because we find probably just as much autoimmune, IBD, infections with these DWI sequences. But we certainly find in the majority of cases when we have a subtle oncologic lesion, we find that the diffusion weighted sequence was the key in that diagnosis
Mm.
or that detection and then the downstream diagnosis. So that is why we use 1.5. It's a little bit counterintuitive. And, everybody else that's practicing in their more organ system focused world, they don't immediately understand this, but once they've been in the practice for a while, they do. And this is another theme with Prenuvo is we have all sorts of skeptics, which I applaud, and critics, which, I also applaud to a point, as long as they're open to what's actually going on. But none of these people, almost none of these skeptics or critics are actually practicing the medicine we're practicing firsthand. So you can imagine, sort of like someone near imaging, like let's say a cardiologist, if they had a lot to say and they're criticizing a different radiology care model, you might say, yeah, that's a smart person. They're a doctor. They maybe have a point. But at the end of the day, they really, they're not a firsthand practitioner, and maybe they need to get closer to it to understand what's really going on. And with almost any criticism that we could discuss, and I'm sure we'll discuss some today, that lack of firsthand knowledge is really a lot of what's driving the lack of understanding of not just Prenuvo, but any of the practices that have this proactive approach to data gathering.
Interesting. Now, Prenuvo is also set up a little bit differently in terms of your staffing model and your network. Can you talk about that and how your approach differs from some of the other whole body MRI companies?
Yes, in our model, all of the radiologists are either contracted with or fully with Prenuvo. So either they are reading a fair amount with us as 1099s, or they are W-2s that are fully employed. And at this point, the majority of reads are being done by people where that is most of their practice. That is either all they do, or it is the vast majority of what they do. And the first 100 or so reads, we are looking very closely, and in often cases for a subset of those, we're doing even double reads. So we really have like a training program and an indoctrination and an OPPE type equivalent an FPPE type equivalent to onboard these radiologists, because what we do is different than the rest of radiology. It's a blend of the type of focus you have as a screener, maybe in mammo or in prostate or lung, but you're extending that across the whole body. And the most important thing here is the ability to detect abnormal from normal, and to understand the threshold at which to raise an alarm and either go to that next test, or in rare cases, make an actual full diagnosis based on the non-contrast scan. Other places are kind of sending this out, and I think I understand that. I mean, I did years and years of running health systems and launching programs like value-based care. And in these ACO and value-based care programs, we all believe very deeply in what we were doing. But at the end of the day, we also realized we were engaging people on a small fraction of their business. So maybe 80% of their panel was fee for service and 20% was value-based care. It was always a real challenge to get people to change operations and change the way they approach every patient and make it appropriate to value-based care versus fee for service. I think here the problem is even bigger. This is what we call in medicine and innovation, the foot in two canoes problem. I mean, you can be really good at doing a canoe when you're in it, right? But if you're trying to do it in two canoes, you're going to look kind of like a clown, right? And that's the fear whenever you mix your business with these operations that don't necessarily gel. So you can imagine the challenge of doing this whole body MRI, and I kind of talked about some of the intellectual mindset that's different. If you're doing that with 5% of your business, and I think honestly in many of these cases is even less. So I envision someone who's reading mostly other stuff, and then maybe half a day, one day a week, they get in this chair where they're reading a whole body MRI. That's a problem,
Yeah.
I think, to do it well. And I think there's another model, which is, well, we'll just take the body and we'll deconstruct it in every organ system. And you actually might get like slightly better individual reads than if you are just doing whole body, let's say 10% of the time. But then you run into the other problem with the US health system, which is you have now a ton of information, but it doesn't all go together. And so the art of this is sort of like primary care, is that you need to take this information on the whole body, and most of the time, you are not detecting a singular thing which gives you a clear next action. So if I find an Oncorad's 5 lesion, like a super suspicious lesion in the chest or the breast, that obviously becomes a pretty focused thing where that's okay, you got to go get this worked up. This might kill you. Or if I find an 8 millimeter circle of Willis aneurysm or something of that nature. But most cases, 19 out of 20, aren't going to have that kind of linchpin finding. And so instead, we have lots of information, and much of it is useful. But the idea is, how do you prioritize this? How do you make it digestible for the patient and their doctor? How do you go from this whole body, we'll say a billion data points or something like that, right? Maybe thousands of different images, and distill it to three things or something that that patient can focus on until their next exam to become a healthier person. And that process is not facilitated by taking a whole body, sending the brain to neuro, sending the lungs to cardiothoracic. That creates a lot of extra steps and makes it much more costly. You perhaps can then bring all that deeper information and diverse set of perspectives and reporting styles. You can perhaps bring that through a couple more layers back to a primary care doctor. But I'll just tell you, it's going to take more. So we believe in the specialized generalist model, right? We take people that are specialized in MRI who then further specialize in whole body, but they're acting somewhat as a generalist. And it's less important for them to say about a brain lesion, hey, I know exactly what that is. That's a pineocytoma or something along those lines, right? That's exactly a stage whatever glioma. It's more important for them to be able to say that is not normal and that is the type of lesion that needs the next test, right? Just like you would see in any screening modality.
What kind of clinical conditions has Prenuvo screening been most effective at in detecting early? Are there any specific diseases where you found MRI to be like a real game changer?
I would say, one of the ones that surprises people is fatty liver disease because all sorts of people have this. MRI is really the way to diagnose it within imaging. There's some interesting stuff going on where maybe you can diagnose it with like a chest X-ray and things like that. I'm all for that. Other ways of risk stratifying for this are great. MRI can, I mean, effectively diagnose it. There aren't too many people out there that after the MRI fat quant are going to recommend a biopsy these days. I mean, it's really you sort of see the biomarker, and then a GP or endocrinologist will have the patient either do lifestyle modifications. In some cases, they might. I mean, it's off label, but it's increasingly popular. They might put them on GLPs or something. It's up to them, but they will do that, and then they'll bring them back in and measure it, either with us or they might just go out and get a dedicated measurement. But the big thing here is that people who are proactive want this type of information. And there isn't a lot of other ways they can get it. And I have plenty of people that I'm close to who have had stone cold normal labs who aren't obese, who have either moderate or in some cases severe fatty liver disease. And that's either a hallmark of metabolic dysfunction or just isolated hepatocellular dysfunction or maybe both. And it really does need to be worked out. That's one of those things that there's a pretty high probability that something's going on that you're going to want to get a control of. You're not going to want to be in that state of ignorance about that for decades until you wind up with either cirrhosis or some other serious issue. So so that one, because it's so prevalent in the general population, I'm told this is about 30%. In the Prenuvo population, which is a little more proactive and perhaps people are a bit healthier, it's about 20% have this in some way, shape, or form.
Mm.
Of that 20, about half have at least moderate to severe, and about 2% have severe. And even the ones with mild, like this is something that is usually in their top three of what they're being told to optimize on. So I'd say that is sort of the big one. Neurodegenerative is another big one. We in radiology, uh, neuroradiologists know this. I think a lot of folks don't. But when most of us were training, you didn't have MS unless you had a symptom of some sort, and they had to be separate in time and place. And then you did the workup, and if you found certain biomarkers either in the CSF and or imaging findings, you fulfilled what they call McDonald criteria for multiple sclerosis. There is now this concept of asymptomatic MS where you don't need to actually have the symptoms, but if you have the right types of lesions and the right biomarkers, even if you don't have symptoms, you're considered to have MS. And there are increasingly places that will treat you, typically academic centers of excellence. And it's early in this because they didn't revise that criteria until 2019. But the idea with this is that with disease modifying therapies, so these biosimilar type therapies, if you can prevent that demyelination, the earlier you get in there, the less that the fire has a chance to rage, right? Like, so you not only preserve organ function, but you actually keep the disease probably at a lower level, like out of that spiral of increasing intensity. So if that's the case, then diagnosing asymptomatic MS becomes now like the focus, right, of neurological clinics that treat it because they want the best outcomes and they would rather have people walking in to get treatment, right, than coming in a wheelchair to get treated for like an end stage disease where they can only do so much to help that patient. So that's the type of, and so that there are other neurodegenerative diseases, the most common one being Alzheimer's. It's sort of a different set of things there, but we are able to detect many of these things in their earliest forms. The most common thing we detect in neurodegenerative disease is also something I think worth talking about. And that's just diffuse white matter, microvascular ischemic changes. And for years, as radiologists, we sort of sit there, whether we're generalists or neuroradiologists, and we're reading, let's say, an ER head CT, and we see this stuff, which we see in almost every 60, 70, 80-year-old. And we sort of rattle out this thing like in non-specific white matter changes, in this age group, most likely to be microvascular ischemic changes, and we kind of like there's nothing like that's in the findings. It's not in the conclusion. We sort of just, it is what it is, right? But as an individual, do you want to see these things starting to show up as you get imaged, however you get imaged? Because what it means really is there's a little part of non-functional or dead brain matter in there. And I think most of us would like for the wires that connect our neurons, which is what this white matter is, we would like for there none of them to be dead for as long as possible, right? So the idea of quantifying these things as it goes on, there is now an emerging field of preventative neurology, right? So not neurosurgeons and not neuroradiologists, but sort of internal medicine type doctors or neurology type doctors. And they're thinking, yeah, like if this is related to microvascular health, then we should do interventions and have protocols that preserve people's microvascular health. And it's probably good not just for their brain, right? But the heart. So depending on who you talk to, one is either the most important organ or the other, right? The heart is either important because it pumps, blood to the brain, or the heart's the most important organ, but it's one or two. And they both share this common thing, which is the most common cause of long-term morbidity and mortality of these microvascular changes, which then often presage macrovascular changes and heart attacks or strokes, et cetera. So we're seeing all this stuff as it happens. And there's a school of thought that just says, well, those people should be living a healthy lifestyle anyway, Dan. Like, why do they need to come get a Prenuvo scan? And I say that's a good question too, but there's no question that human beings engage more when they have visual evidence that some general truth you told them is not just generally true, but it is particularly true in them, and they are already experiencing consequences from it, which could get worse. And that's the big thing is all these lifestyle things, you get patients much more engaged when they know they have fatty liver disease, when they know they have microvascular ischemic changes, when they know that they have potentially early signs of Alzheimer's, which, by the way, Alzheimer's as we're learning more and more, that is very amenable to lifestyle changes. You can ward off a lot of symptomatology, perhaps not forever, but you can really extend, your cognitive lifespan and your health span. But you got to engage the patients first. And I think that that's really the biggest and most important thing about Prenuvo isn't just early detection of things that can kill you. It's actually empowering patients and engaging them with data about their bodies so they do a lot of the stuff that, yeah, they should probably do anyway.
Yeah, well, talking about, Alzheimer's, there was a paper that just came out a couple of weeks ago that correlated brain age, which in part was calculated with MRI scans of the brain with super agers, and people who are aging into the late 80s and 90s and they're still quite healthy. And there's really fascinating findings there. Now, you've mentioned a couple times the data that you've been acquiring. So let's drill into that a little bit more. So Prenuo is doing all these scans every day of people who are, mostly asymptomatic, but you're acquiring that data and research is a big part of what you're doing there at Prenuvo. Can you talk a little bit more about that and maybe what kind of studies that you have underway?
Absolutely. And I'll just start by saying we believe the largest data set of MRI with diffusion in world history. UK Biobank is famously a very large, great data set. It's very deep, right? It's deeper than ours. They have more different types of data, and they have a lot of MRIs there. But to our understanding, they don't have as many with diffusion. And because of the importance of diffusion in early detection of many things, we think our data set is quite unique for that reason. And our biggest goal on the research side is to make this data available for humanity and to make it available in particular to researchers at centers of excellence who are going to do with it things that we can't. And not just that we can't do technically, but things that from a credibility perspective, because at the end of the day, we're a for-profit company and we recognize that our opinion of our data will always be sort of taken with a grain of salt. And so we welcome collaboration from all quarters, and we have a number of collaborations with some of the best AMCs out there. I'm not going to get into individual names, but we've begun publishing. So if you just Google, you'll see, some of the investigators we work with.
Yeah, and we published some of those studies in the Imaging Wire.
Absolutely. And that the theme of these things, right, is that we have massive amounts of individuals and huge data sets in MRI. If you combine that with AI segmentation capabilities, you can do a biomarker approach to massive amounts of people, and you can correlate that with various different things. You can correlate it with other measurements from the images themselves, or you can correlate it with things like patient-reported health outcomes or other elements in what we call our MIF. So our MIF is our medical intake form, and it is a large review of systems type questionnaire. We capture a lot of patient-reported data about their general state of health. And then we combine that with all this morphology data that we get from the images plus AI to create these massive cohort studies that sometimes they're sort of, I would say, stating the obvious. They're testing like, okay, well, we think that, let's say, exercise is good for your brain. So we would expect that exercise is associated with lower rates of atrophy. And there's certainly a small number of studies, but the end numbers are kind of underwhelming in the literature. So we were able to do one that had thousands of patients. And it's just a study you couldn't have done in the past, right? Because you didn't have AI. It would have taken something like 1,000 residents and graduate students to sort of trace all these things out. So we're making the best use of the data that way. And over time, we will do more. We're going to wet our information sets up with other types of data. And this will allow us to do more correlation with things like blood biomarkers or histopathological cancer diagnosis versus patient reported, which is the way we've done our previous few studies. So the more mature we get in our own research infrastructure, the more we'll be able to correlate this huge data set with other things. But our preferred model of research, right, is that we make the investments around the infrastructure and the cleaning of the data and the gathering of the data and the permissioning of the data. And then the best minds in medicine from AMCs bring their best questions and hypotheses, and we help them test them.
So, Dr. Duran, you mentioned research, and some of the Prenuvo research has found that 93% of participants that you've scanned have had at least one diagnosed finding. How do you make sure that these findings lead to meaningful health interventions rather than unnecessary patient anxiety?
I'm always surprised by that statistic, and I'm surprised it's as low as it is because, imagine you spent your whole life walking around with your clothes on, right? And then one day when you were 35, you went to a doctor and took them off. You'd be surprised if that person found only one thing that made your eyebrows raise, right? But it wouldn't be a reason to go around the rest of your life, with never looking at your own body or having a doctor do it. I mean, and that really is as simple as Prenuvo is. I mean, we are sort of in the dark ages and now we can see. And once you look inside someone's body, yeah, you find stuff. So the art of this is not different than the art of the rest of medicine. I could switch that back around and say, how do you make sure that when somebody goes to the primary care doctor that they don't get stressed out about something that's found, right? And then you kind of quickly say to yourself, well, the only way I could be certain there's no anxiety is if there's a 0% probability they find anything. And in that case, they shouldn't go, right? So there's this like circular reasoning. Part of the way we do it is the way we communicate. I mean, we really do believe in this highly structured approach of finding everything that's there, classifying everything that's there according to a certain risk, and then using medical group guidelines within our medical group, along with the IT tools we have, to create a report that explains these risks, these findings and their associated risks, most of which are low, by the way, to the patient in lay language. And then we also have an encounter with a licensed provider, either a nurse practitioner or a preventative medicine physician, who will then explain this to the patient. And we have a general policy. If people need more explanation, they can always come back to us. And in some cases, rather than being our provider, there are concierge type practices that do enough Prenuvo scans where we hand directly to them and they are the ones because they're expert enough that they can explain the findings to the patient. But we only do that when we know that they really understand what they're talking about. So the biggest thing is just because there's such a range of things we could be talking about, like literally thousands, right? And if you think about all the permutations and combinations, it gets into the beyond millions of different ways of types of findings you could have in different combinations. But the unifying principle is to think about an objective measure of risk associated with these findings, and then think about how you're going to communicate to that patient and what their next best action is. What we know about anxiety is all internal data, and I can share some of that. We definitely need to, and with any AMC person who's listening, this is something we'd love to study with an external partner, again, just for that added layer of objectivity and credibility. What we have observed internally is when we ask people with a Likert scale what their baseline medical anxiety is, we get a reading that is typically below 5, but it's measurable. So 5 out of 10. So we'll say like middling, right? And that makes sense. They probably wouldn't be as proactive as a group if they weren't a little bit concerned, either generally or about something. The concern, I think, can come from one of three areas. I'll just quickly say, because I want to work in my messaging campaign here. I'm sort of on a campaign against the use of worried well, maybe more generally, but with regard to our patients. Who are our patients and what are the three reasons they might come in? Well, there's people that have nothing wrong with them. They are asymptomatic, but that doesn't mean that they shouldn't be concerned. Some of these people are high risk people that might have a family history of Lynch or BRCA. There aren't a ton of extra steps that the USPTF gives them to go beyond the average person, but they still live with that knowledge of knowing they're at increased risk. And in many cases, this is very personal knowledge because they've had a direct relative, maybe a parent, die of this, right? So this is something that is on their mind, and they're out there with anxiety. We're not causing that anxiety, and in fact, as you'll see in a second, we're often alleviating it. Then there's the people who are out there that are normal risk that don't have one of those things in terms of genetics, but they do have an occupational exposure of some sort. So maybe they're a fireman, maybe they're a first responder, maybe they're a Gulf War hero who's a burn pit survivor. Maybe they were someone just near the scene at 9/11. There's a lot of different subjects, whether it's environmental exposure or occupational exposure that actually lead to long-term cancer risk. And we know about more and more of these as time goes on. And then there's a group of people that are just proactive and concerned. And some of those people might be concerned because they're getting older. And increasing age is a risk, is a big risk factor for cancer as well. So that's not a nonsensical, illogical concern to have either. Lastly, there is a group of people that actually do have symptoms. But if they were to come to us and say, "Hey, Dan, I was on the football field last week, doing an adult flag football game, and I think I blew my knee out, and I want a whole body MRI," we would tell that person, "Well, go get a knee MRI," right? But if they come to us and say, "Dr. Durand, I have brain fog, I have hurting in all my joints, I've gotten maybe 6 or 7 imaging exams, including a brain MRI previously. No one's ever been able to figure this out. Now people are starting to tell me I'm crazy. Like I want to get a whole body MRI to see what I find." I mean, that's a totally reasonable request. And what's very rewarding in what we do is we can often focus those people on something that is maybe driving their symptoms, or something they didn't know about, honestly, that they should know about. So those are the different types of patients we have. Worried well, are some of them both worried and well? Depending on how you define worried and well, probably. Who's also worried and well? The majority of patients in every health system across this country that go to their annual checkup. I'm worried well. Brian, you look like a smart guy. You don't look that sick. Maybe you're worried well. I don't know. Right?
Let me tell you about my
Nothing wrong with that. The ACOs and everybody else, which I used to help lead, they don't get to call these patients compliant, good adherent patients when they're in their room, and call them worried well when they're in our room. That just, so I sort of reject the notion. Do we have people, is it possible that Prenuvo, like every other healthcare provider in the country, could have people coming to us that are high anxiety that then, come back to us and sort of, no matter what we tell them, are going to remain anxious? Those people are in every emergency room in the country. And I'm sure we have some of them in Prenuvo. I'll be honest with you. Attend a lot of the quality patient complaint meetings. I am not aware of that is not a big source of noise here. And it's been a bigger source of noise at other places I've worked in before. So I think a lot of people think that that's what drives our business, or, some of our critics do, and it's just not true. In terms of how we do on this anxiety, so I mentioned they come in, they're like middle of the road. After they get the Prenuvo scan, as a population, that reading is lowered by a little more than a point. So in other words, the baseline medical anxiety of this broad population averaged out is lowered. And the majority of people, when asked, say they feel reassured and less anxious
Mm.
after Prenuvo scan. There is a subset that feel more anxious, but that's also to be expected because it's a very similar percentage to the amount that we're diagnosing something in. And you kind of can't have it both ways, right? Like we can do our best, but once it's like, I don't have information, I want it, and then I get information. Everybody wants the box to have reassurance in it. Some people find an aneurysm in the box. That is the nature of this. It's also the nature of any time you go for any preventive care. when you go to the dentist, when you get your colonoscopy, right? So that by itself is not a criticism for Nuvo. And the next, and I'm going to let you ask the next question, but so now that I've said like, hey, I think we reduced anxiety, the critics, right, and the haters, right, that their next thing will be, but it's false reassurance, right? And that's also nonsense, but we can sort of talk through it.
Well, Dr. Duran, before we close, I'd like to give you a chance to talk about where you see Prenuvo going and where you see whole body MRI going in, let's say, the next 5 years.
So whole body MRI is going to really become a mainstay of conventional medicine over the next decade. I don't know if it will be within the next 5 years or the next 10, but I would be very wrong in a very public way if it is not by the end of the decade. And what do I mean by mainstay? I mean, look, mammography is a mainstay. Unfortunately, only 60% or 70% of people actually get it as frequently as they should. So it doesn't mean it'll be in every that everybody will have access to to this or choose to have access to it, but it will be something that is widely agreed upon. And we'll look back in 5 or 10 years and say, wow, it was really just starting back in 2025. The features that will allow it to do that are there will be more and more data and we're already seeing this every year. The publications are going up exponentially. There will be more and more access points and people doing it, and that will be good and bad because some people won't do it right, and some people will do it great. Some people will do it better, right? But we're seeing that now, just widespread adoption. Part of that is because there's just so much chaos and compression and rates. The legacy healthcare system. And again, I can appreciate sensitivity to this because I spent so much of my life leading these things. But the legacy healthcare system is really in crisis, and that crisis is going to be continuously exacerbated as the baby boomers continue to age and the utilization goes up and the number of providers is flat. It is going to continue to be net, unfortunately, a crisis type situation, and that is going to cause more radiology practices to sort of say, what else can I do that doesn't sort of drive me crazy? And this is actually a very healthy business model because people get a lot out of it. They come in and they come in healthy and they come back, and so you will see more providers embrace it for that reason. And that's why wellness and longevity outside of radiology, like the equivalents of whole body MRI in other areas, all that's growing as well.
Mm.
Because
Yeah.
the public is so sick of how bad the sick care system is that they've now decided they really don't want to get sick, and they're okay if they understand might have to do some trailblazing and do some weird but different things to not get sick than they've been traditionally told, because the people that are so preoccupied with caring for this sick healthcare system that is itself sick, they don't have enough time necessarily to reinvent the wellness longevity part. So you're seeing patients get very active and think for themselves in this area, and it's a very attractive area. The other thing that needs to happen is that the encounter needs to get quicker, right? Less expensive. And fortunately for all of us, this is where machine learning comes in. There haven't been a ton of changes to the way the bore of the magnet and the basic gradients fire over the years, a little bit, but not a ton. 20 years or so ago, people were saying, what about 5T, 7T? That really hasn't proven to be necessary. You do see changes in detector technology. So I think you will see more and more and more efficient whole body coils, and the things that are lighter, easier on the patient. Right now, they're still pretty heavy. So equally accurate, but almost like a sheet of paper. I think you'll see improvements in the whole body coils, but more than that, you will see such improvements in AI that maybe this can be done at even lower field strengths. Maybe it can be done on an open magnet. And I don't know if it's a decade or 15 years, but I do think at some point in my life, I'm looking forward to this. I get to lie down on a flat thing, not inside an MRI, and it's not very noisy. And I lie there for like 20 minutes, and then I get up and I have the same set of information it takes us, 30 or 40 minutes in a like a 1.5 type wide bore machine to get today. And I think when we arrive there, it'll be a lower cost service. It won't have any claustrophobia associated with it. We have I think, low claustrophobia out rates. We have ways of dealing with this today, but that will bring more people in, right? And so these are the things that will help us scale. And AI, because we'll be obtaining so much more data, not just from these things, but from things like skin photography, retinal scans, genomes. polygenomic risk scores, right? Way more than a primary care doctor can understand. So without AI to sort of take all that and compress it into something the patient understands, that engages the patient, that gives them the next 3 to 5 best actions to take over the next 3 months, 6 months, a year, whatever the interval is in the future, like none of it works. So that's what it'll look like. It'll be part of an armamentarium of tests. It'll be done hopefully in one sitting. Hopefully it'll be done very quickly and in a very simple setting. And then there'll be AI. And when it becomes that simple and we have that much scale, it may be something that you're not doing every year. You might be doing it every 6 months. You might be doing it every 3 months. It really depends on what gives people the best results.
Hmm. Well, it's going to be a really exciting future to see. Well, Dr. Daniel Durand of Prenuvo, thanks so much for being with us today. It's really been a fascinating discussion, and I really appreciated learning more about the company and what you guys are up to.
Thanks, Brian. Thanks for having me, as always.
Yep. All right, signing off for the Imaging Wire. My name is Brian Casey.